Hi, everyone. Thanks for joining us. We have some great information today on your reproductive health. We are talking teens and when your teen should actually go in for a pap smear or see a doctor or a midwife. We have legendary Dr. Mostafa Abazid, who is going to share his 15 years of research that may finally help women who have had multiple miscarriages. And we're helping some of you who are getting to that age where you're going into menopause. Maybe you're in menopause or post-menopause. Now, all of these experts are going to be answering your questions live. So if you want, you just text me your question to 248-935-2562 or send your question over to Facebook or YouTube, and I'll make sure that the doctors get your question and get your answers, okay? Now, we're going to start with Dr. Jennifer Brown, certified nurse midwife. She has a master's in nursing and a doctorate of nursing from Kentucky's Frontier Nursing University, though she loves Michigan. She is especially interested in fertility consultation, perinatal depression, menopause, and empowering women. Thanks for joining us, Jennifer.
Hello, my name is Jennifer Brown, and I'd like to contribute to the Healthy Living series by discussing family planning. I am a nurse midwife, and I work with a lovely group of midwives here at Hurley. The term midwife is sometimes misunderstood. Basically, we're nurse practitioners that can help women from the time they start their period until well after menopause. We do labor support and delivery here at Hurley. But today, we're talking about family planning. And our goal is to improve pregnancy planning to achieve desired birth spacing and family size while also preventing unintended pregnancies. Michigan reported 52% of unplanned pregnancies in the year 2017. Planning improves health outcomes for infants, children, and their families. Family planning services include contraceptive services, pregnancy testing, basic preconception management, sexually transmitted infection counseling, breast and pelvic examinations, as well as breast and cervical cancer screening. Now, preconception health refers to the health of women and men during the years when they can have a baby. It focuses on taking steps now to prepare for a healthy pregnancy. Being healthy benefits everyone and is especially important for a future baby. Since more than half of pregnancies in Michigan are unplanned, we'd love to work towards our goal of family planning by caring for the health of women. Unintended pregnancy can delay initiating prenatal care, reduce the likelihood of breastfeeding, increase the risk for depression, physical violence, low birth weight, physical and mental health of children, and behavioral issues in teens. Now, during a preconception visit with the midwife, we will focus on you being your healthiest self. We will look at your past medical history or any chronic conditions that you might have, review your diet and exercise, talk about your emotional health, start you on a prenatal vitamin with folic acid, talk about immunizations or any medications you might be on. And then we'll also discuss smoking, drinking, dental health, sexually transmitted infections, and intimate partner violence. Contraception allows women the power to plan their reproductive life. A contraception visit will include the risks and benefits of each method, and then an alternative to each. This is one of my favorite posters to explain the differences of each method, the effectiveness of each method, and then with informed consent, you can empower yourself with ensured understanding that you made the right choice for you. And if you change your mind, it's okay. Now, empowering teams to claim their reproductive health is something else the Hurley midwives can help you with. The most important developmental tasks of teens relates to sexual maturity. The child's body undergoes complex changes, waking up sexual concepts and personal values regarding their sexual behavior and sexual health. Our job as parents and providers is to help them decide if they're ready for sexual intimacy and encourage them to assume responsibility for their sexual behavior. Studies have found that sexual communication with parents, especially moms, is associated with increased safer sex behaviors in adolescents. It's important for them to be active participants in the decision-making process concerning their gynecological health. This improves their ability to negotiate personal values about the types of sexual relationships that they're proud to conduct. Abstinence or delay in sexual activity is the ideal protection. However, 50% of high school students are having sex. Contraceptive counseling does not increase sexual activity or the number of partners, but education and family planning services does reduce the pregnancy rate. Teens require special attention to improve the effectiveness and continuation of contraception, with the goal of reducing unintended pregnancies, while also improving their sexual health. PAPs do not need to start until 21 years old. And then we can test for sexual transmitted infections through urine. So for most cases, there's no reason for your teen to have a pelvic or genital exam. Unless there is a specific need, most teens don't need that exam. Other than contraception and sexually transmitted infections, we commonly see concerns related to puberty or menstruation, like painful periods, irregular periods, or abnormal bleeding. Interestingly, the typical timing of the first period is 12 to 13 years old, with African American girls starting a little on the earlier side. The first 2 years of menarche can be very irregular, so that causes some questions for some. Ovulation is only happening about 50% of the time. It can cause longer periods or skipped periods. Eventually, your cycles will become regular. So there you have it. Family planning improves health outcomes for infants, children, women, and their families. Focus on being your healthiest you. Claim your power to plan your reproductive life and take responsibility for your sexual self.
If you have a question for Jennifer Brown or one of our other experts, make sure you go ahead and text me 248-935-2562, or you can post those questions on Facebook and YouTube. We do have some questions. The first one, I have a young teen with terrible cramps and bloating. It sometimes leads to being nauseated. Would birth control help ease those symptoms?
So birth control might ease those symptoms, but as the midwife, I'm always going to start with things that we can, instead of going straight to medication, we're going to focus on diet and exercise, sleep, and what else is going on. So that's going to involve a visit just sitting down with both the adolescent and the parent together and figuring out what is happening on a very basic day-to-day cycle, and then going from there. But yes, contraception might be the answer for her.
I think some people probably were a little surprised to hear that you might not even need a pap smear until you're 21. Someone is asking, should my teen still come to see you to talk over changes to their body or issues to look for, while they're a teen up until that age?
Ideally, it would be great to see girls come in between 11 and 13 years old just to establish rapport, gain that relationship with them. There's a lot that we can talk about, and we focus a lot on education. So education goes a long way.
And we know that it's nerve-wracking. So a child, for a teen, maybe their first time there, they're already worried. But if they already build up a relationship with you and they feel comfortable, it might ease some of those tensions, I think.
That's always our goal.
Can my teen ask for birth control on their own?
So usually they're coming in with their parents. We do allow alone time so that there's not a disconnect. We're always going to encourage having full transparency, but I guess the short answer is yes. I think we have to have, that is one of those sticky situations where we would have to have permission.
Okay. And if you're missing a period, if your child's missing a period, how do you know if that's normal and you should just let it run its course, or if there's something wrong and you need to go see someone?
If you have to ask why, then probably you should go see someone.
All right. Oh, let me see. I might have one more here. Can I make an appointment for my preteen to discuss these changes to her body?
Yes, please.
Okay. Thank you, Jennifer, so much.
Thank you.
Again, you should definitely call us, text us, 248-935-2562 if you want any of your questions answered. All of our experts are here. That's why they're here live, so that they can get to your answers right away and help you out. You can also post on Facebook or YouTube. We appreciate you, Jennifer. Thanks for coming in. Next, we're going to go to Dr. Mustafa Abazid, and let's face it, he is a legend in Michigan for helping families improve their family unit with infertility, and a residency at Wayne State and fellowship at Alabama. He's an expert in reproductive endocrinology and infertility in both men and women. He does both laparoscopic and robotic surgery of endometriosis and uterine fibroids. And today, Dr. Abazid is sharing his 15 years of research in the diagnosis and treatment of recurrent pregnancy loss. His findings are exciting, so let's get right to it.
Hi, everybody. I am going to talk to you today about what I believe is a very important topic. In general, and especially nowadays, there is a lot of talks about the problem of recurrent pregnancy loss. In fact, there has been a lot of buzz in the media about that problem and its impact on couples who are trying to have a baby. By definition, or what does that mean? It means that a couple who have 2 or more failed clinical pregnancy. In other words, you conceive and you miscarry 2 times or 3 times in a row. What's the likelihood of this happening? Actually, it is a very common problem, and it happens to 10 to 15% of all couples who are trying to have a baby during their reproductive years of life. This is what's called sporadic pregnancy loss. But when you look at the incidence of recurrent pregnancy loss, which means 2 or more in a row, it's about 1% of all women during their reproductive years of life will suffer from this problem. The incidence can be higher as female advance in their reproductive age to reach about 1 in 4 or 25% at age 40. So what are the reasons for this recurrent pregnancy loss? This slide illustrates that in almost 50% of cases, there is an underlying reason that can be detected usually by blood test and radiological testing like ultrasound, X-ray with a dye, etc. And obviously, if you find a reason, you direct your attention to treatment of this underlying etiology, okay, and hope that you correct the problem. Unfortunately, in 40 to 50% of cases, we don't find any underlying reason based on the workup and the tests that we did. And as you may imagine, this is very frustrating for both couples and physicians. Because if you don't have a reason, how do you fix a problem? When we reach to that situation, there are few choices for such couples. One choice is to keep trying to conceive and hopefully the problem correct itself, but obviously at the expense of the emotional distraught if miscarriage happen again. The second option is based on the assumption that a lot of patients with this quote-unquote unexplained factors for their recurrent loss could be actually representing increased incidence of chromosomal abnormalities in the fetus during this pregnancy or in the embryo during this pregnancy. With that assumption, there is a lot of reproductive endocrinologists who are now offering in vitro fertilization after testing the embryos, and you can see that this is illustrated here. This is a nice looking embryo that can be biopsied by taking 10 to 15 cells of that embryo, freeze the embryo, subject the tissue that was biopsied to testing, and obviously if you find 1 or 2 embryos that are chromosomally normal, these can be put back and hopefully solve the problem. Unfortunately, this is expensive and it doesn't guarantee success, and most health insurance unfortunately don't cover it. Therefore, there is a lot of people in our field that say, no, that's not the right way, maybe just wait. And in fact, there are some studies showed that just waiting and expectant management can be as successful as expensive management like in vitro fertilization method, and actually had a lower median time to pregnancy. It happened faster. Finally, in these circumstances, what's being offered is to see a reproductive immunologist to find out whether the immune system of the mom is attacking this pregnancy and leading to the loss. And although that may be a good idea in certain situations, it's not the ideal in all cases, because A, the test available to diagnose such immunological reaction is of limited value and not that sensitive or specific. And furthermore, the treatment, which is expensive and not covered by usually health insurance, is no guarantee that it will work. So you can imagine when you give this information to the couple, where do we go from here? Very recently, we published this paper that addressed the role of what's called diagnostic hysteroscopy in the diagnosis of subtle anomalies in the uterus that can lead to recurrent pregnancy loss. Actually, I've been working on this for more than 15 years. And what we observed is that routine testing that usually done to determine whether there is a problem or not, namely ultrasound, especially what's called 3D ultrasound, which is believed to be the gold standard and the way to find out about these anomalies, is not really a gold standard, and it's not as sensitive and can miss a lot of pathology. And I'm just going to show you some pictures. So here is a patient that the ultrasound showed very subtle issues that would be read as normal, but when you look inside the uterus by a scope, that's what the hysteroscopy is. You can see differently. You can see that there is a significant pathology, and in turn, basically you found the reason now that the ultrasound, didn't pick. Same thing happened for another anomaly called significant arcuate, very similar. There is a slight heart shape that the ultrasound is not picking, but that hysteroscopy or scope can determine that there is a pathology here. This is what we use for measuring that dip from the roof of the womb to define whether you have this problem or not. And that's how we fix it. It's a very simple procedure. You basically divide that ridge that's present in the fundal area or the roof of the womb that can be leading to miscarriage, because you could see there is a lot of scar tissue there. That's that whitish area that we cutting. This is not a very healthy area for implantation or for pregnancy. And actually, just showing you here another case. You can see the scope, the finding here, and how we divide that ridge and how the end result is. In other words, now the cavity of the womb is in a better shape to allow pregnancy to continue. Here's another situation. This is basically the video that I would like to show you. So in this video, you can see a live surgery in which the diagnosis of this, what's called short incomplete septum, was determined. And we are moving on at the same session of correcting that. And you can see it's really very, very simple procedure, obviously in experienced hand, that you take this ridge down as illustrated here by using a device with what's called monopolar cautery to divide that ridge and basically flatten the roof of the womb to make the cavity of the womb more normal and get rid of what's believed to be the reason for this quote-unquote unexplained. But you could see now by hysteroscopy, by that scope, the unexplained is now explained and it can be corrected. And very briefly, this is, and I don't want to, those who are interested can actually look this paper up. This is the overall population. And this is the two types of anomalies. One is called incomplete septum, and the other is significant arcuate. And basically, it's showing that on ultrasound, the measurement is markedly underestimated compared to the real measurement during the scope. And the conclusion then from this study, that the data from this study suggests that 3D ultrasound, which is believed to be the state of the art and the gold standard by almost everybody to make the diagnosis of this condition, is actually underestimate these lesions, and in turn, it's not as gold standard as everybody think. And a diagnostic hysteroscopy, which is the surgery I just showed you and discussed with you, should be part of the workup for any patient who we're told she has unexplained recurrent pregnancy loss. Unfortunately, that is not part of the workup until now. So really the important message then is fine. You find out that there is a subtle anomalies of the uterus. You find a reason for this recurrent miscarriage. What do you expect if you fix it surgically? And this is a published abstract from our group showing the outcome after dividing that ridge or septum after surgical correction. And I'm just going to briefly show you what happened, and that is, you can see the pregnancy rate, and that's great, obviously. The miscarriage rate went down to what you see in normal population, and the delivery rate is here, and the best outcome birth rate. So basically, in summary, about 50 or 60% of the patient, depending on what anomaly, uterine septum or significant arcuate, is to be expected to have a live birth after diagnosis of this issue and correcting it surgically. The conclusion from the latter study is excellent reproductive outcome can be expected after hysteroscopic surgical correction of such anomalies of the womb in patients with unexplained recurrent pregnancy loss. Thank you very much.
And this is a great opportunity to get your questions answered from an expert in this field. You could go ahead and text me 248-935-2562 or go to Facebook or YouTube. Dr. Abazi, thanks for joining us. Someone is asking, do I need a referral from my primary care doctor to see you? I've had multiple miscarriages and had given up trying.
Thank you for your inviting me. No, it all depends on, I guess, the insurance. There are certain insurance that's HMO that certainly require a referral by the primary care physician in order for us to authorize doing testing, etc. But most of the insurance, like Blue Cross and others, that's not managed care or HMO, one can call directly and make an appointment. Obviously, if that individual had workup somewhere else, it would be nice to see what has been done and review that before, which is part of the consult.
Someone says, I'm 38 years old. I've had 2 miscarriages and 1 live birth. Am I too old to try another successful pregnancy?
No, not really. I mean, obviously, that reproductive age or her reproductive age is catching up with her. But there are 2 issues that's on her side. One, she has 1 child already. And that's when you look at the data about this, that people who had 1 child and then end with having recurrent miscarriage, they do better than somebody who never had a child and had recurrent pregnancy. So that's one thing in her favor. The other, that 38 is better than 39 and definitely better than 40. So no, I would definitely, say that if she wants, she has a chance. And the question is, what are the reasons for the miscarriage? Is it purely her reproductive age, which certainly can increase her chance of miscarriage, or there are other things that is happening that could contribute to the miscarriage, and if found, hopefully can be corrected, and maybe that expedite have success.
There's a question. Can you get this procedure after one miscarriage, or do you wait until there's been multiple?
So one miscarriage is called sporadic miscarriage. Every now and then one can have miscarriage, and about 10-15% of females during their reproductive years of life, they will have that kind of miscarriage. Um, the recurrent pregnancy loss is by definition that there are two or more in a row. Okay, so we normally don't go through extensive workup for miscarriages until at least two miscarriages occur.
How long after the procedure can I try to get pregnant?
Are you talking about the procedure that I just described?
Yes.
We normally say about 2.5 months, because usually after 6-7 weeks, we do another ultrasound with what's called, with some fluids called saline sonohysterogram to make sure that the outcome, surgical outcome, has been achieved before we allow the couple to start trying again. So I would say 2.5 months or so.
I've been told I can't carry to term, but I didn't have this procedure. Is it worth pursuing now?
Well, I'm going to assume that the question is that we have a situation in which the patient or the person who's asking the question had preterm labors, okay? And I'm not sure whether she was told there is a reason or there isn't. If she was told that there is a reason, obviously we should direct our attention to the reason. If she was told that it is unexplained as to why she's having preterm labor, she would fit in the scenario that we are talking about, although the presentation today is addressing the recurrent miscarriage, which is by definition either early miscarriage before 12 weeks gestation or up to 20 weeks, and that will be a later second trimester miscarriage. But apparently the question is about preterm labor, which is after that. My gut feeling that the problem that's causing recurrent miscarriage that we illustrated by the hysteroscopy and so on certainly can lead to preterm labor and other obstetric complications. So that individual would be actually encouraged. She has to have testing to find whether she has anything in the uterus, whether it is this anomaly that I discussed, or subtle things like fibroid tumor or others that can lead to. Obviously, there are many other reasons for preterm labor that should be looked at as well.
Before I get to the last question, there are some comments here. Dawn says, best person and doctor around. Thank you, doctor, for being so kind, professional, and thorough. You are an angel.
Thank you.
This question says, I've had 2 miscarriages with no diagnosis reason. Would you recommend this diagnostic exam before we try for a baby? I've never carried beyond 10 weeks.
Certainly that individual fit in the definition of recurrent pregnancy loss, being the fact that she had 2 miscarriages. It depends on her age as well. If she is young and she doesn't want to have any workup or procedures, she could try again. But obviously, if she miscarry again, definitely she would benefit from the procedure. Now, I'm saying that with heartache because I know how much the suffering of an individual when you have a miscarriage or the couple. But I'm just simply trying to answer the question. If it was me, I would say no. I would 2 miscarriages more than enough to look at every facets and angle out there to determine if there is something that can be fixed. And nobody can guarantee anything, but at least reduce the likelihood of another miscarriage.
All right. Thank you, Dr. Abazid, for joining us. And thank you for devoting so much time to this research and, giving people hope and a chance to have a baby if they really want one.
Thank you so much for having me.
If you do have a question, you can, submit it to us. You can text me at 248-935-2562, or of course on Facebook or YouTube. Finally, we're going to get to Dr. Omari J. Young, who is an expert in healthcare disparities, menopause, minimally invasive surgery, uterine fibroids, pelvic pain, and endometriosis. Now, after a residency at Harvard University, Brigham and Women's Hospital, Massachusetts General Hospital, he returned home to Hurley and is helping us today with midlife reproductive health and menopause. Dr. Young?
Hi, this is Dr. Omari J. Young. I'm an obstetrician and gynecologist at Hurley Medical Center. I'm happy to be speaking on gynecologic health, midlife to menopause, as a part of the Hurley Healthy Living series. Disclosure, I have no relevant financial or non-financial relationships in the products or services described, reviewed, evaluated, or compared in this presentation. One of the most important topics I want to present first is the well woman visit, what encompasses that visit, what does it entail, and what questions that each woman should ask at this visit. Preventative care and screening, contraception counseling, and family planning, menopause, and hormone replacement therapy. So the first subject I would like to address is the well woman visit. The American College of Obstetricians and Gynecologists states that the well woman visit provides an excellent opportunity for the patients to maintain a healthy lifestyle and to minimize health risk. This is an important topic because this visit includes screening, evaluation, and counseling, and immunizations based on age and risk factors. More than 50% of preventive care visits for women were to their obstetrician and gynecologist. So even though that we're a specialty physician group, we do provide a lot of primary care and preventive care for women in the community. A particular sensitive topic when it regards to the well woman visit is the use of the breast and pelvic examination. Over the last 10 years, the recommendations have evolved on the importance of this aspect of the well woman visit. Particularly in 2014, the American College of Physicians recommends against performing screening pelvic examination in asymptomatic, non-pregnant adult women. Also, the American College of Obstetricians and Gynecologists recommends breast and pelvic examination only be performed when the medical history or symptoms indicates. So the old adage that if coming to the obstetrician requires a breast exam or pelvic examination is not indicated anymore unless you are experiencing significant symptoms or your medical history indicates that requires the need to further investigate with a breast examination or a pelvic examination. Another important part overall gynecologic health from the midlife to menopause is preventive care and screening. This involves general health screening, sexually transmitted infection counseling and screening, cervical cancer screening, breast cancer screening, other cancer screening, and osteoporosis screening. Like I said before, obstetricians and gynecologists have a unique opportunity to address non-reproductive health at the well woman visit. This can include depression screening, anxiety screening, blood pressure checks, diabetes screening, and intimate partner violence screening. So many other areas that are very important to the overall well-being of a woman that is not just specific to gynecologic health. Cervical cancer screening. This is very, very important screening because it's very much a preventable disease. The incidence of cervical cancer in the United States has decreased more than 50% over the past 30 years due to widespread screening. Most cases of cervical cancer could occur in women who have never been screened or were not screened adequately. Per the American Society of Colposcopy and Cervical Pathology, which is the ASCCP, low-risk women should begin cervical cancer screening at the age of 21. Between the ages of 21 to 29, cervical cytology, which is the pap smear that most women know it by, should occur every 3 years in low-risk women. From the age of 30 to 65, cervical cytology should be done every 3 years or cervical cytology with HPV every 5 years. We know that there are also preventive measures that our women in the community can do to also reduce the risk of cervical cancer outside of just routine screening with their obstetrician and gynecologist or primary care physician. Transmission can be reduced by limiting sexual partners, using barrier contraception, and reducing smoking. But again, this is a very preventable disease, and having routine screening can have lasting impact. Breast cancer screening. This is a very important screen because breast cancer is the second leading cause of death among women in the United States. Annual mammography should be beginning at the age of 40 annually in average risk women. But there is a subset population of women who are at a higher risk. And this has been very popular in the media, given cases of actresses known as Angelina Jolie and other celebrities who have stated that they had risk-reducing surgeries to prevent breast cancer down the road. And this is called hereditary breast and ovarian cancer syndrome. Most commonly in the community, we know this as BRCA or BRCA gene mutation. This is an inherited cancer susceptibility syndrome characterized by multiple family members with breast cancer, ovarian cancer, or both. In women who are deemed to be at high risk, meaning that they have first-degree relatives, or if they have the diagnosis of breast cancer themselves, should consider genetic counseling and genetic testing. And based on the diagnosis, there can be a discussion between your physician, your genetic counselor, with regards to risk-reducing surgery, which could be a risk-reducing mastectomy or removal of breast tissue, or risk-reducing removal of your fallopian tubes and ovaries. The next subject is contraceptive counseling. Contraceptive methods allow women to actively prevent unintended pregnancy and control the timing of a desired pregnancy. The method should be based on shared decision-making, taking into account the patient's desires and medical history. There are multiple options available to women. The decision should be your own and with your family and your partner. There are many hormonal and non-hormonal options. There are many long-term options, which we call long-acting reversible contraception, or LARCs, which can also give you reassurance of decreasing the rates of unintended pregnancy. But ultimately, like I said before, it's a shared decision between you, your family, your partner, and your primary care provider. Menopause. This is defined by the absence of the menstrual cycle for 1 year. Occurs between the ages of 45 and 55, with the average age being 51. This is due to the decrease in ovarian function characterized by the hormones estrogen and progesterone. The clinical presentation of menopause, as most women know, is vasomotor symptoms, which is highlighted by hot flashes and night sweats, and vulvovaginal symptoms or vaginal dryness. These symptoms can range from 6 months to 2 years or last as long as 10 years. So this can cause a significant impact on a woman's quality of life, and there are options available to you. The standard treatment for menopause symptoms is hormone replacement therapy. As stated before, the cause of menopause is decline in ovarian function or the decrease in amount of estrogen and progesterone. So replacing those hormones will resolve those issues and improve the quality of life. The treatment should be provided for the least amount of time and the lowest amount of dose. And particularly, there should be a detailed discussion with your obstetrician and gynecologist or primary care physician regarding your eligibility for hormone replacement therapy. Because historically, we have known in the past that given in the wrong patient population, there can be significant complications and morbidity. Particularly, this treatment plan is contraindicated in women with a history of breast cancer, coronary artery disease, blood clots, stroke, or active liver disease. For these patients, however, we have non-hormonal options that are available for them to treat these symptoms, which can, again, cause significant morbidity due to the hot flashes and vaginal dryness. So there are options for women who have pre-existing conditions and risk factors for hormone replacement therapy. As we approach past menopause into the next stage of a woman's life, which is postmenopause, another significant condition which can cause morbidity to women is osteoporosis. This is significant because more than 50% of women will experience an osteoporosis-related fracture in their lifetime. This is due to, again, the decrease in hormones, estrogen and progesterone, which leads to decrease in bone mineral density. Screening for women should begin at the age of 65 with a screening test, again, that measures bone mass density. Again, this is a very significant disease that can cause a lot of morbidity, as I stated before, which includes many fractures. The goal of treatment is to prevent, and that's why you should get regular screening in low-risk women at the age of 65. And women who are deemed high risk based on risk calculators can potentially require screening before the age of 65. Another significant condition that affects the quality of life and the morbidity of women is pelvic organ prolapse and urinary incontinence. This is a disorder that impacts the quality of life of more than 50% of women during their lifetime, particularly women who are postpartum. Screening should be offered for women of all ages and women in the postpartum period. Pelvic organ prolapse is due to the decrease in pelvic floor support. And again, this is age-related and also can be impacted by lifestyle changes and childbirth. Ultimately, the goal of treatment is to, again, improve quality of life. The clinical presentation for pelvic organ prolapse is something that most women can relate to. Usually they feel pelvic floor pressure or bulge. This is commonly associated with urinary incontinence or the loss of urine. Most commonly, women will endorse the symptoms of unintended loss of urine with exercise, cough, sneeze, or holding any kind of pelvic pressure. There are many options to treat this, whether it be pelvic organ prolapse or urinary incontinence. And again, ultimately the goal is a shared decision, with options being medical, which can include, like I stated before, lifestyle modifications, conservative medical management with a pelvic floor support with a device called a pessary, which can be placed in the outpatient setting, or surgical intervention to strengthen the pelvic floor support and to improve quality of life. There are a lot of preventive care measures and screening tools at our disposal to improve the quality of life and to decrease the morbidity and mortality of women. Reach out to your obstetrician and gynecologist, your primary care physician, to answer all your questions and concerns.
We do have some questions coming in, and if you'd like to add a question, go ahead and text me at 248-935-2562, or you can add it to Facebook or YouTube, and we'll get Dr. Omari Young to answer those questions for you. The first one comes from Amy. She says, I've skipped my 2020 exams. Is it safe to come in for a routine exam during the pandemic?
That's a great question that we get commonly, given the COVID-19 pandemic and the concerns of contracting the virus, especially in the hospital setting where we're treating COVID-19 patients. I want to reassure all women that we are taking all the necessary social distancing precautions, mask wearing, and hand hygiene. So it is perfectly safe for you to come in to get routine care. Because as we've seen over the past year, a lot of unintended morbidity has occurred when women and our patient populations has elected to stay at home and neglect chronic conditions or new acute conditions. So if there's something concerning, you're more than safe to come into the hospital setting to get care.
And if there is something wrong, like a pap smear, something shows up there, it's not something you want to wait, because doing it quicker could actually have a better result.
Exactly. Waiting can potentially make the outcome worse, particularly if and that's the purpose of the cervical cancer screening, is to prevent and catch things early. So if you postpone care because of the fear of the pandemic, you could potentially catch something at a later stage.
Dr. Young, Laura is asking if there's proven success for non-hormonal treatments for menopause.
Yes, there are a couple FDA-approved options. Interestingly, antidepressants, particularly SSRIs, have been FDA approved as a non-hormonal option for menopause symptoms, particularly the vasomotor symptoms, as I stated before, the hot flashes and the night sweats, and then also gabapentin is a non-hormonal option that's been FDA approved for the treatment of the vasomotor symptoms related to menopause. And then also, if you just have the vaginal symptoms, then you don't have to take what we call systemic or oral or patch. You can treat it locally with ointment or gel, which will not have the same side effects as taking the pill or using a patch for hormone replacement.
Someone says, now that I'm on the other side of menopause, how frequently should I have a pap smear?
So pap smear, as long as all your preceding pap smears have been normal, you should continue routine screening every 5 years with the pap smear, which we call cytology, and also co-testing with the HPV, because we know that the HPV virus is associated with the development of cervical cancer. So you should continue regular pap smear screening every 5 years from age 30 to 65. After 65, if all of your preceding pap smears are normal, you do not need to continue any cervical cancer screening after the age of 65.
Are there side effects to hormone replacement?
Yes, there is. Particularly the major side effects or concerns that we worry about that made hormone replacement therapy go out of favor are blood clots and risk of stroke. And then also in certain patient populations, depending on your history, there are slightly increased rates of breast cancer. So that's why before making the decision, we do a thorough history of your personal history, family history, to make sure that it's safe.
This, I guess, would go kind of with that. Do I only do hormone replacement if the symptoms are unbearable?
Exactly. So anytime a woman comes in with menopausal symptoms, my first question is, how is it impacting your quality of life? If it's having minimal impact, you can just do lifestyle modifications, which is controlling the temperature in your home, cooling yourself off, those kind of conservative measures. And then if those don't work, then we can talk about medical management.
Okay, thank you, Dr. Omari Young, for joining us and answering those questions. I'm sure it's very helpful for some of the people. I do want to thank all of you for joining us. We do hope that this has helped with your own reproductive health. And if you need to make an appointment, you can go ahead and go to hurleymc.com. We have all the different doctors on there. You can search them up and find out their pages and their numbers if you want to reach out to them directly. Hope you guys have a great afternoon.